All right, let's go ahead and get started with the debate session. So I'm Karen Wu, and I am joined by
Yazan Doueri
and Emilia Kroll.
And we will be moderating the debate session. The way this is going to work is the debaters have been told that they have 5 minutes each. We're going to give them a little bit of leeway because 5 minutes is kind of short, but they will have a hard stop at 6 minutes, and then they will each get a minute of discussion or a rebuttal, and then there will be 11 minutes allowed for audience discussion. So, with that said,
Thank you, Karen. So the first debate topic is TCAR versus CEA as a gold standard for carotid disease. Of course, carotid endarterectomy has stood the test of time over the years, and TCAR over the last decade or so has expanded its indications from high-risk patients to standard-risk patients. So we'll start by Dr. Jim from Minneapolis, taking the side of TCAR as a gold standard for carotid disease. Dr. Jim.
Great, thanks. All right, so I was asked a few months ago to participate in this, so I'm very excited for the privilege of the podium. So I always start off with some disclosure slides. I think most of you guys know who I am. I work with Silk Road as a consultant, participating in clinical trials, as well as a lot of the educational activities. So I was asked by Karen, I think a few months ago, I got an email, and I was very excited. She invited me to the meeting and says, hey, can you help debate TCAR replacing CEA as the gold standard? So, 2023, when you're going to give a talk, there's really only one place you're supposed to do this. You go online, you go to ChatGPT, and try to figure out what it says. So I had this whole discussion. I said, all right, hey, can you help me prepare the debate that TCAR has replaced CEA as the gold standard at SCVS? And I got a nice reply. It says, well, yes, TCAR should replace CEA as the gold standard in 2023. However, I advise against you from debating this, though. And I said, well, that's weird. Why? I mean, it's a great discussion for the audience. Look at all the people there. Well, you have a good argument, but this is not a popular opinion, and you're going to get booed off the stage. well, I don't think it'll be that bad, will it? So I said, let's see. Well, yes, you will be booed. The surgeon's going to, vote with their hearts and not with their minds. Karen Wu probably just doesn't like you. And my buddy Yazan there is probably not going to help me. And you're debating Wei Zhao. And I said, yeah, absolutely. She is amazing. She's great. She's a leader in vascular surgery. Well, exactly. She is an NIH-funded researcher, right? She's a thought leader in carotid disease and wrote the recent SVS guidelines. And there's me. I said, yes. And it's weird when the ChatGPT actually has to think about it for a little while. And I was a little worried. I said, well, what about me? Can you tell me a little bit more? Well, you know how to spell TCAR, and you will get destroyed. So I'm a little worried about what's going to happen in the next 4 minutes, but I agreed to participate already. What should I do? So this is the advice I got. Talk fast, confuse everybody, and try not to embarrass myself. So here we go. I know I got a little bit of an uphill battle here, trying to take the audience to convince you that CEA may not be the best to go to TCAR land, but that's my goal and my hope here. I think everybody's sort of familiar with CREST. It's shown us that potentially transfemoral stenting may be a failed experiment, but what it did show to us is that it's actually a durable procedure. If you look at long-term outcomes, it's pretty much similar to what happens with CEA. The problem with transfemoral stenting, as you guys know, is the problem with delivery of the stents. You have problems up front in the first 30 days, but it's not really a performance durability thing. Everything sort of matches up over time, as you can see with this graphic here. What TCAR produces essentially is an alternate way of delivering that stent in a way that you eliminate that or lower the 30-day more problems associated with it, and then leverage that long-term outcome. You guys are pretty familiar with the concept of TCAR. Essentially, what it does is combine transcarotid access, so you can avoid the arch that complicates with transfemoral stenting, and it has flow reversal as a way of protection. Combining those two techniques essentially mimics what you can get to CEA. This is some of the clinical data looking at DW MRI, looking at essentially the protection is so good it mimics exactly what CEA does. It's very different than transfemoral stenting. So everything, all the biases you have against stenting, it does not apply here. Well, all this, does it translate clinically? The answer is absolutely. When you look at the clinical trial results from ROASTER 1 and ROASTER 2, it showed up with results are amazing, never before seen, and actually way better than standard of care, gold standard, carotid revascularization studies, which is the CRUST study, right? We all know that 4.1% for transfemoral, 2.3 for CEA, and we're able to beat that out of the water with both of these trials. Now, a lot of you guys are going to sit there and say, hey, listen, this is carotid disease, right? We need to have level 1 RCT data, right? I see him in the crowd there. Dr. Schermerhorn taught me this. In order to really debate this and figure this out, we're going to have to have a randomized control trial comparing CEA and TCAR with about 60,000 patients on each side. So I'm going to let you guys on a little bit of secret. I think that's going to be CREST maybe 4 or 5. So in about 30 years, we'll figure out exactly which one's better. Now, for those that want to argue with randomized control trial data, that's excellent, but we've known that it doesn't apply in real world. This is a classic study done over 20 years ago now looking at CEA. Even the results of high volume centers, trial centers, places, the hospitals that are doing these procedures, you're not going to be able to mimic what you get from ACAS and NASCET. The results are just not as good in the real world because you're not taking carefully picked patients. This is not something that's unique for CEA. This is something you see within stenting studies as well. It doesn't necessarily apply to all of your patients that you see. So what we have, luckily, we have VQI with the TSP. We're able to see pretty much 90+% of all the patients that get TCAR. We have the data within it. As you can see in the blue here, the outcomes that you're looking for with stroke and death are essentially equal. But, if you kind of carefully look at it, I know nobody in this room, I don't really know what a cranial nerve injury, and I'm pretty sure nobody here has seen one, but I heard those things can happen. If you look at CA and TCAR, essentially TCAR lowers the MI rate and almost eliminates a cranial nerve injury, and people get to go home. It's an easy procedure to learn. I've had the opportunity to teach a lot of you guys how to do this procedure. We're proud in the fact that we're able to translate, our knowledge to your skills, and people that actually do this at the very beginning, novice operators, are able to get good results from the get-go. Certainly you get better in terms of efficiency as you go along. There's data that shows if you adopt this into your practice, you do better. Your whole program improves. So who gets a TCAR now? I'm wrapping up because they're looking at me funny over there. And based on anatomy, looking who's qualifying, based on what we learn about TCAR from transfemoral stenting, about 70-85% of patients can get this. So to summarize, last slide, clinical outcomes, we know that this is better in many different ways. Patients love this. Go ask a patient who's had both, which one they prefer. And finally, this is something that we like. So when it's said and done, I think it's going to be the gold standard, and I'm going to get off the stage. Thank you.
Thank you. All right. Well, this was a great argument. I invite Dr. Wei Zhao from University of Arizona to argue for carotid endarterectomy.
Okay. So I think I have an easier task. So CEA has been tested for over 60 years. Numerous randomized control trials has tested CEA against best medical therapy, transcarotid stenting, and TCAR procedures, and has remained the gold standard, has proven durability with good long-term outcome. Now surprisingly, SVS carotid guidelines recommend that for low surgical risk patients with asymptomatic over 70% stenosis, CEA with best medical therapy is recommended over the best medical therapy alone for long-term prevention of stroke and death. For symptomatic patients with over 50% stenosis, CEA is recommended over TCAR. Now, TCAR come over vascular surgeons like charging bull. The procedure has double, triple, quadrupled over the last several years, but where's the data? Has TCAR been objectively tested against other alternatives? And has TCAR proven durability? Here's a ROSE 2 trial that Dr. James will talk about. As you can see, there's a per protocol analysis and the intention to treat analysis. The rate he was mentioned about the 0.6% and 0.8% respectively, but in intention treat group analysis, the rate of stroke is 1.9%. Let's say if you have a patient who has massive stroke during the procedure that prevent him to have additional dual antiplatelet therapy, that would exclude the patient from the protocol, but it would not kept in the intention to treat analysis. So the trialists state, most importantly, ROSE 2 is a single arm study without a comparative group. Now, fast forward 2 years, this is 1 year data for ROSE 2. As you can see, Dr. James, the co-author, he also has lots of ties to the procedure and then the industry. Again, In this study, it's coded as per protocol analysis, 0.6% all stroke. Remember the intention to treat analysis, the stroke rate is much higher. Now, for ROASTER 1 trial in this data, there's more subject at 1 year than 30 days. I didn't understand why. I assume this is based on the per protocol analysis. For ROASTER 2 trial, less than 1/3 of patients has data over more than 1 year. So since we don't have randomized control trial, let's look at the registry data, right? Since we don't have the long-term outcome data, let's look at the short-term outcome, the 30 days and 1 year. So this is an analysis from VQI data from a relatively non-biased group of vascular surgeons. As you can see here, both at 30 days and 1 year, CEA has lower relative risk of death and stroke than TCAR or transfemoral stenting, is superior than TCAR and transfemoral stenting. Now, let's look at the standard risk patient. This was just published by Dr. Schumacher's group. After propensity matching of TCAR and CEA data, look at VQI analysis again. So remember, the procedure was selected as discretion of the treating physicians. This is VQI data. So if a patient who has high risk for TCAR, significant calcification, disease, common carotid artery, one would not really select TCAR for this patient. So despite that, CEA has less stroke rate than TCAR at both 30 days and 1 year. And 1 year, again, 1 year follow-up for TCAR was really poor, about 1/3. Not much better for CEA either. So CEA remained better than TCAR for standard risk patients. Now let's look at cost-effective research. And this data was published last year. Look at cost effectiveness. The author assumed TCAR has very low risk, same stroke and death rate as CEA, lower MI risk. Despite such a generous assumption, CEA is more cost-effective than TCAR. So it's not surprisingly that the most recent SVS carotid guideline did not make any recommendation for TCAR because the level of evidence of data was relatively poor. So TCAR has not objectively tested against alternatives, has not proven durability. There's no long-term outcome data available. It really have not met the criteria for the gold standard, and CEA remained the gold standard as of to date.
What do we do now?
Well, Dr. Jim, you get a minute for rebuttal.
I gotta go get up. Can I not have her slides up? We did this. No, I mean, I think one of the criticisms that it's already set up as a failure. No, I think one of the criticisms I think we always hear about the ROASTER 2 trial is the difference between intention to treat and per protocol, and that is absolutely true. I think one of the things that we probably do want to mention though is even with intention to treat, and including even those patients that have violated protocol, the stroke rate, as she mentioned, was 1.9%, which is still lower than 2.3 that you saw in the CREST. So despite that, it's still significantly important. One of the things that we learned from that, and that's where we really have objective data, is the importance of medication therapy, which, as you guys know, we don't let people do those procedures unless they have that. It really highlights it's not something that is not reproducible in your institution. Now, in terms of looking at long-term data, that's true. You don't have anything more than 30 or 1 year data. But the difference is, we're testing a technology in terms of how we're putting the stent in. There's excellent long-term data, especially with this particular stent in terms of the outcomes. So we can certainly wait for that, but I'm not sure it's going to show any significant difference. A stent, once it's in place, it's going to act exactly as a stent that was placed in a different way. So with that, I think one of the things I always want to highlight is about patient selection. You're right in terms of choosing the right patients. So far, TCAR has really been chosen for the worst patients that nobody wants to operate on. As we go ahead, we want to be a lot more careful in choosing those patients. I think you can get the results that you're looking for. Thank you.
Right. Dr. Zhao, you get a minute for rebuttal.
I really don't think I need a rebuttal. I think Dr. James really said, agree that with every single point I made. And one thing I just want to make for the CEA risk, That was a 15 years old data. So with best medical therapy, the risk of stroke and death rate perioperatively is much lower than what we know back in 1995, 2.3%. So I think with that, the CEA still have a better outcome than TCAR. And the rest of the point, and Dr. James already made.
All right, well, we're going to open the floor for discussion. We have room for some questions. Go ahead.
There we go. So my name's Robert Hacker. I'm in private practice. Let me take a step back and ask you a question. Gold is for everybody, correct?
Yeah?
Ubiquitous. Maybe TCAR is Bitcoin and carotid is the gold standard. Because let me tell you a real world perspective. Take away all the fancy titles and all the lovely institutions that you guys have. You can't do a lot of these procedures in hospitals. I've been to the course with the doctor, right? We did the Silk Road stuff, I don't know, 2 months ago. I can't get credentialed because the paperwork for the credentialing process is antiquated. Therefore, it's not an option for me. My two partners who are about my age and experience, about 7 to 10 years out, all they do is TCAR, and now they can't do open carotids because they forgot how to do the procedure. I did an aortobiofilm on a guy the other day, and he had an unmasked lesion. You can't take a guy who is as sick as him and put him on a fluoro table. It's not available. And one of the hospitals doesn't even have the technology to do it. So if gold is for everybody, you got to be able to do the procedure on everybody at every location at any time. What do hospitals have? They have nurses who at least know what a clamp and a scissor is. They can hand you 7-O-Proline. You don't need a shunt, I would argue, and you don't need a patch. And that can be done by everyone. And my stroke rate is 0% since I graduated fellowship. Thank you, Dr. Macaroon, for teaching me good technique. So I would argue TCAR is sexy and great, but would you want that stent in your neck? Because when I have my risk and benefits discussion with my patients, I give them a pathology bottle with a endarterectomy sample in it, and then I show them a stent, and then I tell them my stroke and risks, and I say, you choose what you want. I got partners who do stents, or I can take this out of your neck. And 100% of the time, they don't want that in their body. 100% of the time. Maybe I'm a good salesman. So I would argue CEA, take away all the data, is proven and great. TCAR is sexy, but it's not available to everyone, and so it's a Bitcoin.
I kind of wish I got into Bitcoin a while ago still, so I don't know how to answer that one. I mean, I think, one of the challenges with anything with carotid stenting as a vascular surgeon is going to be credentialing locally, and that's going to continue to be a problem, especially when they're sort of relooking at the NCD. We have a lot of other specialties sort of running those kind of committees, and that's going to be a challenge. But ultimately, when it's said and done, it sounds great. It's a great show to sit and show people, hey, listen, I have 0 stroke rate, because I don't think anybody in this room has ever seen what a stroke after a carotid intervention is, right? So that's excellent. You do enough, you're going to get one, and hopefully just 1 or 2. It sounds sexy to remove the stent, remove the plaque and not put a stent in, but the data doesn't bear it out, right? If you look at long-term, even look at CREST, 10 years is long-term is exactly the same. I was floored by that as a junior person looking at this, right? Your restenosis rate is 6% 2 years, regardless of therapy. Your stroke rate's about less than 10% in 10 years. It doesn't matter. It's how you get them through that first 30 days. And that's what we learned. And I think that's what's unique about TCAR. It's not really doing something completely new. It's just how you put it in that's different, and then you're relying on the same stent that's been studied for over 10 years.
I totally agree with you as far as CEA remain the gold standard. There's a patients that TCAR is maybe a better option, but definitely not the gold standard. One thing I want to warn the graduating resident fellows, we need to learn how to do CEA. As vascular surgery, we need to do it and do it well. And otherwise, we're going to lose that skill.
How's it going? Andre Kurtznelis, surgery resident at Mount Sinai down the street over here. Thank you guys for a great presentation. Topic I'm very passionate about as well. I completely agree with your point. As a hospital that's actually really converted to TCAR, I have very limited experience with endarterectomy, so I do think it plays a big role in at least the training paradigm. My question to you guys is, you just mentioned the restenosis rate. When you're facing a patient that has that restenosis and you have to reoperate on them, do you wish you had done a TCAR at first or endarterectomy? How much more difficult is it when you're facing that restenosis intervention when you've done one or the other as the initial intervention?
I was trained in the area that carotid stenting was very popular. Everyone's get a carotid stent unless there's a good reason not to. So for restenosis after stenting procedure, actually for TCAR, if you look at all the studies, one of the meta-analysis shows about 4.5% follow TCAR procedure in all the studies. And treating restenosis follow stenting procedure require repeat angioplasty, maybe multiple. For CEA procedure after restenosis have treated before, transfemoral stenting or even additional TCAR procedure actually is a much easier procedure, and then in my mind, in my experience.
Yeah, I was going to say, first of all, restenosis luckily doesn't happen very often in either techniques, and a lot of times you don't have to treat, your threshold to treat is a lot lower because they don't tend to have as many issues with it. Redo TCAR is not that hard. It sounds scary to do redo operative CEA. You're just exposing a carotid at the base of the neck, which is pretty big with a giant nerve that you can't miss. So it's not a hard thing to do. Like you said, flow reversal protection is so good. So if you need to re-angioplasty, put another stent in, it's not that complicated.
Thank you.
So, Dr. Jim.
You're supposed to help me, by the way.
Oh, okay. Well, I'll try. You have to help yourself, though. So when we look at replacing any procedure, we have to either look at something that is better, or cheaper, faster. It doesn't seem that, you're arguing for TCAR being just as good as CEA. Is it cheaper? Is it better in any way?
So it's a hard question, so I think it's a fair question up front. Upfront costs, when you look at some of the analysis, just looking at actual costs up front is not, right? Because you have to, a patch is probably a couple $100, right? You do have to buy the system, you have to buy the stent, but what do you actually save that people don't account for is the shorter hospital stay, the shorter procedures. We try not to get too loud about how fast a procedure is for people that do the RUC and the surveys, right? We don't get reimbursed based on how much work we do, but that is the true difference in terms of the amount of time. Everybody's going to tell you guys, I'm sure everybody in the crowd does 50-minute, CEAs, can do 8 of those in their hospital one day, right? I can't do that where I work. I can barely get 2 CEAs done and be the turnover time. I can do a lot of TCARs in one day. So you can get throughput, you can get your cases done, gives you opportunity to make money. So I think it's a hard question. I don't have great data on that, but I think it's not so simple as the actual materials costs.
I'm going to comment on the cost. So one of the paper I showed was from the Northwest, shows a lower cost for CEA than TCAR, despite that assuming TCAR has a better outcome, had lower MI rate and the same stroke and death rate, it still shows better. Another paper that's actually a year before that shows that same from Mamon Manas group, show that CEA has lower cost than TCAR. But authors said, well, in 5 years, at 6 years, the cost is going to be catching up. But if you look at the follow-up data, only 1/3 of patients actually had a 1-year follow-up. So that's a really long stretch for the 6-year follow-up.
Okay. Well,
Baked you up.
I think we all had time to hear both arguments, and it's time to vote. I'd ask the audience to vote by raising hands. First, who would vote for TCAR to replace CEA as gold standard?
So I now know I have 5 friends in the audience. That's good. That's good to know. Thank you. Oh, 6. Mark forgot to raise his hand.
They're all good friends. All right. Who would vote for CEA to remain as a gold standard? All right, well, Dr. Zhao wins the argument. Thank you very much.
Thank you. Did you stay after or did you go back? Did you stay after or did you go down? Okay, all right.
Okay, we're going to move to our second debate. That's going to be about DCB and dialysis access, and we're going to ask Dr. Garcia-Troca to give us our first presentation. Okay, I'm going to have a time.
Thank you, the committee, for the invitation, especially to the program chair, Dr. Wu. So I'm going to add to Jay's comment about confusing everyone with my speed. I'm going to give you guys my accent. So it's tough to talk about DCBs, especially after the meta-analysis of Katsanos, right? But we'll try to make a point. I don't have any disclosures. So just look at these 2 numbers. So there's 233,000 annual procedures to maintain patency on access. And the annual cost for Medicare is $37 billion. And I mean, we need to pay attention to this because we're close to reach 20% of the GDP used in healthcare. So unfortunately, there's this vicious circle of having a functional access, then developing stenosis because of intimal hyperplasia, and then recurring an angioplasty. And this cycle continues. And the problem is that every time that you do an angioplasty, your patency decreases. So, and this is being well studied. So how do we stop this cycle? One is with drug-eluting technology, either with DCBs, with balloons, or with a covered stent. For the purpose of this debate, we're just going to talk about DCBs versus just plain balloon angioplasty. There's been multiple studies in the last 4 years of DCB and AV fistulas, a lot of retrospective studies, more than 40 studies that showed a clinical effectiveness of using this technology, but all these are retrospective studies. So let's show good data. So there's been 5 large randomized controlled trials. One in China using the Aperta balloon that showed a benefit of using this technology. It's a balloon that is not available here, but that uses also paclitaxel with a dose between the Lutonix and the impact balloon, so 2.5 micrograms per millimeter square. Then the two RCTs with the Lutonix balloon that unfortunately didn't show a consistent evidence of using this technology, but it did show at 9 months that if you use a DCB, you get a lesser interventions and better primary patency. But it was the impact global pivotal trial that showed that a benefit of using this, especially at 6 months, that there's a absolute risk difference of 22.8% of target lesion primary patency by using the impact as your primary technology versus just DCB, and this benefit carries at 12 months and 24 months. And as I said, this didn't happen with the Lutonix trial, and I'm sure Dr. Aitken is going to show that. At 24 months, as I said, the benefit carries with the impact balloon with a significant difference, 52 versus 36%. And I just wanted to point this graph that the median time to reintervention, because that's what is the clinical significance, is that your reintervention gets 14.7 months longer. That's a median if you're using a DCB as your primary strategy. So lesser interventions equates probably on better quality for the patients. Unfortunately, we haven't used quality instruments to evaluate these patients in these trials, but hopefully we'll get better evidence in that regard. But definitely there is a benefit on lesser intervention and better primary patency when you use this. What were the authors' conclusions? They all concluded there was a benefit of using this device. So it's a safe strategy. There was no difference in mortality between the two, and it may be also that the mortality in these patients is 30% at 2 years. So it will be tough to find in a meta-analysis a difference in mortality, but it does decrease the reintervention and increases the primary patency. So clinically, it's the strategy we should use. What is the problem? Well, the economics. There is a price tag with this balloon, at least $1,800, and especially 50% of the interventions that we do are on OBL. So there's a price tag that there's hesitance, but it's non-viable to use this unless we start getting reimbursed. So fortunately, there was an economic study after Dr. Wu asked me to do this talk that helped me out to make my point. So this was published a few months ago, and it's a really elegant study that basically what they did was using the impact impact results. It proved that there's a decrease in reinterventions from 2.7 to 1.7 at 36 months that equates in a difference of $4,000 at 36 months if you use a DCB as your primary strategy. This is just on reinterventions. If you use just primary patency as your outcome, that difference carries. And then at 12 months, you can see that, there's a difference in patency of 53.8 versus 32 if you use a DCB. What about dollars? At 1 year, the difference is about $2,000, that if you use this strategy, you actually break even if Medicare starts reimbursing the balloon. So it's our argument to create new policy. And actually, if you carry this at 30 months, the difference is almost $4,000. So if we carry with this strategy, and we use it just in half of the interventions, the 233,000 that I mentioned, we would save Medicare $420 million at 3 years. So just with, that economic value, I think that's a mic drop, and hopefully I win the debate. In conclusion, so DCBs it's a novel strategy. We still need more data, but the evidence from large randomized controlled trials show, even though there's varying effectiveness, they generally demonstrate that a trend towards a significant benefit of using DCBs. And the budget impact of modeling suggests that fewer interventions could lead to great economic benefits. Thank you.
Thank you, Dr. Troca. We're going to ask Dr. Atkins to give us the second side of the debate.
Thank you for the invitation to be part of this exciting debate. When I got the invitation, I was excited, but then I realized I have to go against my friend here, and hopefully we'll still be friends. This is not personal. The data speaks for itself, and you cannot use your accent as an excuse. I have an accent too, so we're on equal footing right there. So in the next 5 minutes, I will, with my accent, will try to convince you that we should only use DCB in selective patients when it comes to dialysis access treatment. These are my disclosures. So we all know the stenosis is in AV access is a major problem. It causes high rate of non-maturation and dysfunction in AV fistulas and AV grafts. And KDOQI recommends the use of balloon angioplasty as a primary treatment for this stenosis. However, KDOQI states that there is inadequate evidence to make a recommendation regarding the use of special balloons such as DCBs. Okay, fine, KDOQI is old, it's 4 years old, and we have a lot of data since then that my opponent presented. But the data is confusing. We have 3 meta-analyses since then, but the data is conflicting. 2 meta-analyses showed that there is better outcomes with DCBs in terms of target lesion primary patency and access patency. But those 2 meta-analyses included all type studies, retrospective, prospective, and RCTs. There are meta-analyses that only included RCT data showed that there's no advantages of DCBs. Since those meta-analyses came out, we have more data. We have 3 more RCTs, as mentioned by my opponent. There's Lutonix data, impact data, and then there's PAVE trial, which is not industry sponsored as compared to the other 2. So the Lutonix data shows that there's some decreased reintervention rates, but the access primary patency and target lesion primary patency is the same in both groups. Impact trial showed improved target lesion primary patency and reinterventions day, but again, the access patency at 6 months was the same. And the most recent trial that was not sponsored by industry showed no advantages of DCB. And again, more data, less clarity. So how applicable is this data to the patients you taking care of every day? Fine, impact trial did show some improvement in DCB group, but is this applicable to the patients you taking care of? That trial included 2/3 of the patients from the US, but 1/3 of the patients were recruited from Asia. And then interestingly, in that trial, 50% of the patients had a forearm fistula, probably not representative of our population. Also, subgroup analysis from this trial showed that there was significantly less advantage in U.S. participants in terms of primary lesion patency as compared to non-U.S. participants. This trial also excluded patients with a history of AV fistular thrombosis. And again, it underlines that it might not be applicable to the patients you are taking care of every day. And is it really worth it? The cost analysis is complicated. We all know the POBAs are a lot less expensive. These are the numbers I got from my hospital. We pay about $100 to $300 for POBA and over $1,000 to $2,500 for DCBs. But I understand cost analysis is more than just paying for the balloon. There's life expectancy, reinterventions rate. There are 2 papers that were published using impact data. Both of them concluded that DCBs can be cost effectiveness only between 3 to 5 years after the primary intervention. So your patient has to survive long enough to see cost effectiveness, and also the access has to survive long enough. But all the trials showed that the access patency is not better in the DCB data. So is it really cost effective? It's hard to know. I'm not arguing today that there's no role of DCB. I'm just arguing that we have to figure out who can benefit from it. I don't think that one-size-fits-all paradigm works in the management of AV access. We have to figure out individualized patient-centered approach, and there might be a subgroup of patients that can benefit from this technology, but currently there's no level 1 evidence to support that DCB should be used as a primary intervention in all patients with AV access stenosis. Thank you.
Dr. Garcia-Troca, we have now a minute for a rebuttal.
Well, I agree with everything you said. No, one of the things that I didn't mention is that with any reintervention or time that you bring them back, is you may be adding time to catheter or putting a new catheter, and that adds on the mortality, and that's not accounted in any of the RCT. So that's another benefit of trying to prolong the life of our access circuit. I agree that the mortality, we need to wait those 3 years, but it's impossible to know which 30% of the patients are going to die, right? They're all really sick, and that should be on detriment on our population and not offer this technology. What I would agree is that it's tough to argue for this until we get, or to do it on everyone until we get reimbursed, because it's definitely not sustainable, especially if 50% of these cases are done in an OBL. It's like, how do you pay for it? So hopefully with this economic analysis, we can create policy to get reimbursement, because I do believe that there's a cost benefit of using this technology.
Thank you. Now, Dr. Etkin, for a minute.
Yeah, so there is cost benefit in certain population of patients, but I don't think we know who those patients are. So our goal now going forward to really figure out, is this some patient-specific characteristics, lesion-specific characteristic that would select this group of patients that DCB works in. And we're not improving access patency. The goal is to keep the access working, and all the trials, meta-analysis, RCT showed that DCB does not improve long-term patency, only target lesion primary patency. So the lesion stays open, but no matter what, the access still occludes, and we still don't know how to improve long-term survival of these access in our patients. So I'm just not convinced.
Thank you. The floor is now open for questions.
I have a question. Why are the results from the IMPACT trial different from the results from the Lutonix trial?
I don't think, one theory is the dose. The Medtronic, the IMPACT balloon has 3.5 micrograms per millimeter square, and Lutonix has 2. Maybe also the excimer, the polymer that is used. If it's indeed the dose, then it does make sense to use IMPACT. Right?
So that's a theory, but there's never been any data to support it. There's actually a couple of animal trials with IMPACT balloon that showed that the dose that delivered into the target tissue is not higher, but the dose in the non-target tissue. So the drug gets washed out faster distally, and the crystal embolizations are higher distally in the tissue. So we actually don't know if putting a higher dose on the balloon really means that you deliver a higher dose in the target tissue. That data, that there's no trials in humans, but there's a couple of animal trials. So it's really unclear. It might be like patient selection. Also, they had a higher rate of antiplatelet use in the balloon in the DCB group as compared to POBA, but in the Lutonix database, they had the same use of platelets. So another theory is that maybe antiplatelet drugs has something to do with that.
And also the way they did the POVA and the Lutonix trial. So they needed to, it was high pressure inflations for a long time, and also they couldn't abandon if there was more than 30% stenosis or recall. So, they were doing everything right. It was perfect POVA technique, so that might, go against the use of the DCB.
But when you look at the latest trial, the PAVE trial from the UK, their control group had better patency than the DCB group in the other two trials, making the argument if you do a good job at ballooning with a high pressure balloon, maybe that's all you need, just a good ballooning.
My question was, most of the follow-up in the target lesion patency was at 12 months, and we all know that the dialysis patients have terrible follow-up. So maybe to identify the group that would benefit the most, we could utilize something like a frailty index, to identify the 30% that will not survive. Maybe see if they would benefit more from less interventions or, benefit from the use of the device more.
I mean, yes, I agree, but I mean, the technical success is equal for both. It's a balloon, right? So they both look the same. So if indeed it's an economic benefit of using it, then why not? I mean, that's how I see it.
But you only see the economic benefit if the patient survives long enough.
Yes.
They have to at least survive about 3 years, and we know our patients, just this patient population, they don't live long enough.
I agree.
Very nice presentations. So you're both experts on this topic now. So when would you use a drug-coated balloon? What would the circumstances be that each of you would want to use a DCB?
I personally use it if I intervene on the same patient like twice in 1 year. The third time, I'm like, okay, it's time to use DCB.
And my issue of doing that is that with each reintervention, it just gets worse. So and full disclosure, I am a selective user of DCB.
Well, I just won the debate. Okay?
Having said that, after going through all the data and the economic analysis, it really does make sense to use it as your get-go strategy. The only issue is the reimbursement. If it's right now it's tough to argue that. The added cost of the balloon if you're doing it in an outpatient setting.
Well, it's good to know that you both agree on nothing, and comforting to know that you do the same thing.
Okay, I think we're going to, go ahead.
One more. So I'm intrigued by your statement that you're a selective third-time user. So when I went to Ireland and talked to the impact people, I had a post-session with the pathologist. And the pathologist brought me out some slides and said, here is a primary, and here's a post, let's say 2, 3, 4 angioplasty section. Now this was arterial SFAs, but you'd surmise that you're dealing with an arterial segment of vein. The pathologic development of scar tissue is the same. The impact drug, these paclitaxels do not function on GAG. They do not function on anything other than smooth muscle. So once you've set the pathway of angioplasty off and you're getting the second, third session, the paclitaxel's working on nothing. It's worthless. And so when we are talking about using these things, I think that is almost a very important point to realize. What are you treating? You're no longer treating intimal hyperplasia. You're treating hyperplasia of scar tissue. And so I think then we have to start asking, is a stent more appropriate, or is the strategy true? I'm a selective user of drug-eluting balloons, but in the point of target lesion revascularization, dialysis patients are whack-a-mole. So knowing that information, would that change your mind about selectively using it after the third angioplasty?
DCB came out based on the animal models in atherosclerotic lesions, and we know nothing about how paclitaxel works in veins. And we know that the stenosis in fistulas, grafts, it's intimal hyperplasia, not atherosclerosis. So I think this technology was actually never created for AV access, and we just sort of decided, well, it worked in the PVD world and atherosclerosis, let's try it. But I don't think we really understand, it was all based on atherosclerosis to begin with. So I'm not convinced with any of it, honestly.
You did convince me.
Thank you very much. We're going to move to the third debate. Vote. Oh, I'm so sorry. Vote. All right. Who from the audience would use DCB as the first line for dialysis access treatment? Oh, nice. And then who would use it selectively in the dialysis patient? All right. I think we have a clear winner.
Thank you. All right, we're going to invite our last set of debaters up to the stage, Dr. Hingorani and Dr. Chavez. Where's Dr. Chavez? All right, Dr. Hingorani and Dr. Chavez are going to debate on the topic of microaggressions. Dr. Hingorani has the side of microaggressions impact physical and mental health. Dr. Hingorani.
Okay, so this is totally different than the prior two debates. There's no data here, but when I started looking into this, I rapidly realized I know nothing about microaggressions, and I have a feeling a lot of us really know very little about it. So I decided, let's talk about what are microaggressions. So microaggressions are everyday slights, insults, put-downs, invalidations, and offensive behaviors that people experience in daily interactions with generally well-intentioned individuals who may be unaware that they've engaged in these demeaning ways. Because the person who's inciting this may not even be aware of these types of problems, this makes it even more insidious and more harmful. For example, you did really well today. I was pleasantly surprised. Now, this may actually be well-intentioned, but the way it comes off, it's a backhanded compliment. They are also related to the context. They may be related to someone's social identity, such as race, class, gender, sexuality, disability status, age, role, position, religion, etc. And they're often related to an organizational hierarchy, such as being a doctor, or a nurse, or a trainee, or being a junior faculty. For example, a white male assistant professor says to a colleague, "Today someone mistook me for a security guard." You ask, "How did that make you feel?" He responds, "Fine, it was funny." Is this a microaggression? Probably not. His feelings were not hurt, and the incident did not relate to any aspect of his identity. No microaggression. On the other hand, an African-American male assistant professor says, "Today someone mistook me for a security guard." You ask, "How did that make you feel?" He responds, "I am so sick of it. No one ever sees me or people who look like me as a professional with a degree." Same scenario, different context, different impact. This is a microaggression. The impact on the person who's receiving it, they feel hurt. They can be angry, shocked, ashamed, resigned, which I think many people in the audience have experienced this. They may think about the experience for a long time after it happened, and they may be unsure if they're making too much of the experience. They're not even sure if they should bring it up, but they might have a suspicion that if they were in a different situation, or if it were somebody else, they may have had a different outcome. On the point of view for the speaker, however, it's important to separate the intent and the impact. Microaggressions are often committed by well-intentioned people who do not always realize the harm they are causing, which makes them more subtle, unintended, and more complex. They can be cumulative and have an amplifying effect. You get out of bed in the morning, you stub your toe. It hurts. It hurts a lot. You go to the shower and you hit your toe on the bathtub. It hurts again. It hurts even more. You go to put on your shoes so you can go downstairs, and you stub your toe again. Besides being unfortunate, keep stubbing your toe, it hurts even more. You're standing in line at the grocery store after you put on your shoe to pick up something, and the lady in front of you steps back and steps on that toe. She steps on it very lightly, but it hurts like the dickens. These are repeated insults, and they amplify as you continuously have the same problem again and again, or a death by 1,000 cuts. Where did this come from? The term microaggression was actually used by a Columbia professor, Gerald Wing Su, to refer to brief and commonplace daily verbal, behavioral, or environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative slights and insults. He had actually borrowed the term from a Harvard psychiatrist, Dr. Pierce, who had coined the term before. However, he had only referred it to racial problems. Dr. Su actually expanded it across the entire spectrum with work, LGBTQ, gender, age, etc. They can be verbal and they can be nonverbal slights also. And often they identify with a person who's being marginalized or non-mainstream community. Regardless of the intent, these words and actions are often rooted in implicit bias, which are attitudes and beliefs that exist outside of our conscious awareness and control. Some examples. Someone's mentioning that they're feeling invalidated. You roll your eyes. You just invalidated them again. You're turning away from someone or avoiding them altogether. You schedule meetings or events that are conflicting with religious observances or obligations. We've all seen these. And we've all seen the harm that they can cause, mentally and with repeated events physically. You order food for events and not consider the dietary restrictions of others, and only allow certain people to work on high visibility projects. Some examples. You don't sound like a normal black person, you know. You speak English quite well. You don't act like other gay guys. A recent survey with 1,100 workers across different industries showed female respondents were up to 3 to 5 times more likely to experience microaggressions compared to male respondents. If we look at Dr. Chavez, look at her Google profile, we can see that she's very familiar with these issues. She's recently given lectures and been a moderator on some of the Western vascular work that she does for the DEI committee. If we look at her Twitter page, again, she's very familiar with the inequities that exhibit in some of the data between male and female physicians, and some of the other work that she's been done has been very inclusive and looks at diversity. So she's familiar with these. A recent meta-analysis looked at 141 articles, an average of 260 subjects in each one of these articles. In this article, they basically summated the world's literature, suggesting that microaggressions were negatively related to psychological well-being, and physical health. These are everyday insults, put-downs, invalidations that are offensive, and they do affect mental well-being and physical health. Thank you.
Dr. Chavez, full disclosure, I had to do a little arm twisting to get Dr. Chavez to give this side of the argument. Thank you, Dr. Chavez, for accepting this assignment.
Thank you for that. Let's see. All right. So last talk. Thanks for sticking around. I'm Leanne Chavez, as you heard by Dr. Irani. I'm glad to have made it here. Little flight issues. I was tasked with a counter debate topic, microaggressions or perceptions of hypersensitive people. I have no sponsor disclosures, but I do have personal disclosure that this is an opinion-based debate presented to promote discussion, evoke emotion, shame, and anger, and in the spirit of good faith argument. We're all aware that inequities are present and would work toward balancing the scale is often met with questions, what needs balance first? My argument is that the scale has overcorrected. An example of an overcorrection is this story. A blogger wrote about her excitement about travels to India. She explained she had always wanted to visit India for its beauty and exotic character. After her post, this blogger was met with critics of her use of microaggressions. Common among her critics was the notion of white privilege, suggesting that she needed enlightenment of her damaging comments due to her unknowing blinders of white privilege. As an avid traveler myself, I have made similar comments of awe and excitement for my upcoming travels. Why can't a person simply explain their excitement for a well-deserved vacation? Is it not appropriate to visit a foreign country and call it a vacation? Microaggressions have moved us all to a new level, a level that threatens to make us forget what true persecution looks like. Rather than focus on acts clearly committed to hurt a specific group of people, like hate crimes, microaggression can be in any action someone or anyone perceives to be prejudice, which in turn blunts the impact of true marginalized statements. Mean statements or insensitive statements are mean and lack courtesy, but are not assault on human dignity. Listed are some examples I am sure I'll recall stumbling on once or twice. Should we label ourselves microaggressors? The preoccupation with microaggression lowers the bar on the conceptions of evil, and real evil exists out there. Like the ever so common JK, JK, LOL, the term microaggression is used so often it now risks being perceived as a devalued slang. How many people watched the Super Bowl this year? The Kansas City Chiefs were the winners. Did anyone recall seeing this fan televised? What would you say to me, a Native American, if I told you you shouldn't be a proud Kansas City Chiefs fan? Would you go home and burn all your Chiefs jersey gear? Although the prior example isn't unknown to me, it may be unknown to you. But where do we draw the line if there is no endpoint? People are truly finding offense in meager, unimportant matters. In Seattle, city officials have determined that the word brown bag qualifies as racial discrimination. So what shall our kids take to lunch? Well, nothing, right? Because all kids should have to eat the school-made lunch, not only the poor kids who have to survive on school-subsidized meals. Another example of how out of the hand microaggressions are getting is penmanship, the word, now referred to as handwriting, without gender-specific terminology. There's real racism in the world today. There's real sexism, real classism. Violence, refusal to employ, and exclusion from professional organizations are macroaggressions. Why has there been so much recent focus on microaggressions when there are bigger issues at stake? Placing such an emphasis on microaggressions among the relatively privileged or hypersensitive overshadows more serious forms of aggression. Aside from the examples given, what happens when microaggressions no longer serve to notify others of an injustice? But rather, microaggression decreases comments. People are too afraid to say anything wrong or offending the wrong person. As a coping mechanism, people withdraw into comfort zones. Instead of promoting collaboration and ideas and perspectives, we stay in social groups that are just like ourselves. So instead of branching out and being creative or innovative, we are filing into parallel lanes. This does nothing to encourage relationships or understanding. It also drives very damaging groupthink behavior. Finally, the overuse of microaggression violations increases conflict in the workplace through informal complaints, grievances, and tribunal claims. Thank you for your attention.
Dr. Hingorani.
So fortunately, the term microaggression is actually one of the terms that Dr. Su had explored in turning micro insults and in terms of looking at total aggressions. Dr. Chavez has highlighted some of the points that there is a pendulum that swings back and forth. And it's a matter of opinion how far it's swung and is it too much. I would say no. I think many of the people in this room have experienced microaggressions repeatedly every day in multiple settings. And I would say the ball has not swung far enough to identify these types of insults that continue every day. It's unfortunately part of our culture. It needs to be called out for what it is and needs to be at least identified as a problem. Putting your head in the sand, saying that it doesn't exist and that we've gone too far and that we're too woke today, I think is ignoring the problem. And it is a problem. Putting your head in the sand doesn't take care of it.
Thank you, Dr. Hingorani. Dr. Chavez.
So I think I was dissuaded when I saw my face on the PowerPoint slide. Should I have taken that as a microaggression? Possibly. But I'm a professional, and I'm up here to tell you that it doesn't stand to help you to proceed with that continuous backtalk, because you're giving your power away to somebody else. So understanding your self-worth, understanding where you stand, what your character is, and the ability to alter that 180 degrees and present a presentation such as this, I think is an opportunity for growth and improvement. And so taking the stance against microaggressions is necessary to continue to evoke the discussion.
Thank you. So let's open the floor for discussion. Are there comments from the floor? What do people think? What have people experienced?
Thank you both, Nick Swerdlow from Vascular Fellow from Boston. Dr. Chavez, I have a question about, first of all, appreciate you taking that side of the argument. And in terms of balancing, obviously, whether these real experiences that people are having, whether it's female trainees or underrepresented minorities, and not, calling them hypersensitive, but also trying to acknowledge those, but still kind of focus on some of these bigger issues at the same time. I'm just curious how you would go about kind of doing that with either your trainees or students or colleagues.
In my particular practice, so I'm at University of New Mexico. Majority of the time, a lot of our trainees aren't from the actual state. I am from there, and I relate more with the patients than my actual colleagues. So I think I try to just emulate that respect, and that helps a lot.
I'm Michelle from Syracuse. I loved your presentations, and what I wanted to say is where do we really draw the line here? Because quite frankly, I've always been told as a female surgeon coming up, I need to have thick skin. We need to be tough. We have to not be deterred when people throw a comment our way. And I usually ignore most of those things. And I think sometimes we get so bogged down in trying to worry about everyone else's feelings that we're almost impeded in our own progress and interactions, as you've stated. So my question is, should we really be meeting in the middle rather than at each side of the equation there?
I think that it's probably true that the truth always lies between the two extremes. But I would argue that we still are not at the extreme at all in terms of identifying microaggressions. As I said, when I looked it up, I realized I had an inkling what it was, but when I really started to look at some of the science behind what these are, the psychology literature is very precise. There are hundreds of papers that have looked at it in terms of its impact. Who are the perpetrators? What type of impact does it have on the people who are receiving them? We clearly do not understand this, and we clearly need to identify them and call them out for what they are.
Because I would take from that not only do we have to change the way we are doing things to be less microaggressive, but we also have to find a way to treat those of us that have endured many years of abuse throughout all of our training, and particularly as a minority in vascular surgery.
I agree. Go ahead. I agree. I think one of the aspects I think you mentioned, Dr. Shah, is that if you're somebody that's used to being put down consistently, there's a lot of videos and things about abuse and emotional abuse and different things in regular personal relationships, but not so much in professional relationships. And so how, as yourself, somebody who has been a marginalized person, who's sort of like run through the gauntlet and been treated that way, how do you switch the emotion and changes that you've pushed down so much? And I think that's discussions like this that helps. But it also, you have to make it through. You got to continue to proceed on with your professional aspirations. And as a marginalized minority, by threefold, I think unless I find somebody exactly like myself, I don't have anybody to hang out with in a group like this. So how do I proceed on? I figure it out and I move forward and I make connections on other aspects in life. And I think that was what helpful with trainees, is finding something amongst your trainees that is personal, that you can relate with, whether that's asking questions, whether you're asking the right questions, the wrong questions, asking questions at all, I think is helpful. And will open the doors for continued communication.
I have a comment. I think that it's really important for us to create environments where people feel comfortable expressing that they feel like they've experienced a microaggression, and that the person that did it is open to hearing that, and that the two people are willing to work together to make change. Something similar just happened to me, and my colleague called me and I said something off the cuff that was probably disrespectful, and I didn't think about that at the time, but we talked it through. I was willing to own up to it, and my colleague was willing to tell me about it, and we were willing to work towards a solution together. And I think those are the kinds of environments that it's incumbent upon us to create.
When I read all of these papers, I exactly agree. They're actually and we didn't have time to talk about all of the effects that you can have when you've identified an event such as this. There are lots of tools that are written about what can you say, how can you identify these problems, and identify that this made me feel uncomfortable, let's talk about it. Do you walk away? Do you come back later and talk to the person? And there are actually constructs and tools that can be used in each one of these settings, including, as Palma was saying, when you have these repeated microaggressions, sure, you develop a leather skin, but you also become insensitive because you got to get through your day. You can't fight every microaggression every day, otherwise you can't see your patients.
It's kind of what I was going to say. You know, we all know microaggressions probably happen on a daily basis to most of us. And it doesn't have to be a woman. It actually happens probably to men, you know, Black people, Hispanic, and everybody. We all experience it. And it's kind of exhausting to fight it back. You kind of want to let it go. Do you think it's productive to face every microaggression and talk about it? I personally think it's just easier to let it go. Am I allowing people to continue to do it by like not acknowledging it? Or I personally think I'm better off just ignoring it. I might be supporting the wrong side of it. I don't know.
Yay. That's all right, because you're my friend. So I think I agree. Sometimes it is easier. I think you have to pick your battles. The other option is maybe doing it aside in private rather than up in front of everybody, because then that's its own self. It might be perceived as a microaggression. One thing I thought about is currently at our institution, we've had a series of wellness talks, and microaggression has been on the continuous topic. And instead of it being utilized as an actual highlight of some event or misinterpretation, miscommunication, it's sort of just splurted out. And on those instances, I've sort of just kind of kept track of what those instances are to bring it up at a residency conference eventually. But I think that behavior change of the use of the word microaggression is what I think we need to try to limit. And that's what I was leading with my slide presentation.
But at the same time, if you don't identify these problems and don't call them out for what they are, they're not going to go away. You're not going to be able to identify them. You're not going to be able to walk away and come back later and talk to the person. You need to first identify the problem to fix it.
And I think that's a difficult ask of everybody. I think if you are a people pleaser, a young faculty member, you don't want to be labeled difficult. So if you're the one that is highlighting every single instance, then that might not work to your benefit as a faculty promotion. Although not specifically said or identified in your promotional packet, it can still, I think, affect things.
All right, we are not going to vote on this one. Thank you to our debaters. Don't go away, because I'm going to announce the winners of the Carmody competition. So for the aorta thoracic thoraco section, it is Priya Patel. Is Priya Patel here? Or someone from Priya Patel's... Come up and claim your certificate. Aortic abdominal is Clay Whiskey. And if that person's not here, somebody from your team, please come claim this. Cerebrovascular is Winona Wu. PAD is Sina Zarintan. Sorry, I'm butchering your name. Dialysis venous visceral is Richard Mina. And education imaging is Alaska Pendleton. So our finalists will each receive $500 and they will compete tomorrow in the Carmody competition runoff to see who the final winners are. So don't miss that. And that concludes our session. Join us for the gala.